What we've developed in British Columbia, and it's the first of its kind in Canada, is we have a women's heart health network. So we actually have several different clinics at different hospital sites in different health authorities that all talk to each other, and the patients can actually flow back and forth. So we have a clinic at British Columbia Women's Hospital, we have the Leslie Diamond Women's Heart Health Clinic at Vancouver General Hospital, and also we have a refractory chest pain clinic.
ICVHealth has access to clinical data and administrative data, as well as data that we collect for specific trials. What is unique in our methodology, because we have personal health numbers on every individual in British Columbia, we can actually link that data together and follow the entire trajectory for every patient.
Administrative and clinical data really is useful to practitioners and policy people, really to be able for them to do their work. In women's health, as in any health, men or women, it becomes important to have the right data, to have the evidence.
My main focus of research here at Vancouver General Hospital is this condition called spontaneous coronary artery dissection, or SCAD for short. Our SCAD clinic is the largest of its kind in the world. We currently follow over 280 patients with SCAD. We've now added a second registry called the Canadian SCAD Registry, which is a CIHR funded registry that's enrolling patients with SCAD prospectively in about 20 centers throughout Canada and a couple of sites in the United States.
It's very important for ICVHealth to extend beyond British Columbia, and so we are always making new collaborations. So in addition to working with Dr. Saw and Dr. Sedlak here in Vancouver, we also work with Noelle Berry-Mertz, and she's at Cedars-Sinai. She has perhaps one of the most eminent women's cardiovascular research institutions. Through Dr. Saw, we have now collaborations with the Mayo Clinic, and we also collaborate across Canada. We collaborate with Alberta, we collaborate with Ontario, and also with Quebec. There are now more and more pockets of centers of excellence in women's cardiovascular disease, so we actively ensure that we work with and collaborate with those centers.
We provide a women's-only cardiac rehab program here at Vancouver General Hospital. The reason that we started it was because we found through studies, through prior research studies, that women were less likely than men to enroll in cardiac rehab and also less likely to finish a program in cardiac rehab. And so to try to improve cardiac rehab in women, we created a women's-only cardiac rehab where they have women's-only classes and they find that they have a higher comfort level, higher quality of life. They're able to relate more to their peers, and they also have education sessions that are based upon women's heart health.
The British Columbia Improved Cardiovascular Center is really an organization that has been helping researchers in British Columbia develop research ideas into actual research projects and to disseminate the knowledge gained from such research to enhance the lives of British Columbians, essentially. And they've done a lot of work and assisted several researchers, including myself, in developing key objectives that answers important questions on cardiovascular disease.
What's unique about the data that we have access to for ICVHealth is that it's population-based. And that's very much a feature of the fact that we're in British Columbia and we're in Canada, where every patient who interacts with the healthcare system, we capture detailed information on that. So that's actually unique. There are a few other jurisdictions where you could do that. For example, the United Kingdom and many of the Scandinavian countries. And that becomes important. If you have to collect data de novo from patients as they appear, you could get a selection bias. You could either get patients that are extremely ill or patients that aren't that ill. But if you capture the entire population, you can really draw meaningful conclusions from the work that you do.
Peers that review the work and see it as just top quality, that tends to suggest that it really is the best that's out there. And I think that's what you're going to see. We certainly have seen it in the early clinical studies for the center, and I don't see that that will change. That'll something that'll continue to build, and I think it will really drive sort of a research excellence on what's done and the activities of the center, but more importantly, the quality of the data, the quality of the evidence. How valuable that evidence will become more important.
I was originally admitted because I had some sort of unusual heart symptoms about 3 years ago after I had to have some minor surgery done, and I was incredibly fortunate to get a referral to Dr. Tara Sedlak. Well, the caliber of healthcare quality is excellent here, and I think it's because it's integrated into your overall health care. There's a sort of sense of community. The staff here is very knowledgeable and they have access to all of my records, so it's a more complete picture about how my overall heart health is doing. I feel like I'm a partner in that I'm not having something done to me, that I'm actively being part of the solution.